thanks for the introduction. I'm speaking really today because the NRP has been very generous in giving me some money to do some research over the years, and I'll be talking about that a little later on. But I wanted to talk about what a great year in stroke it's been. And Graham's down the front, and he has probably shared the excitement that's happened this year. Because what's happened is that up until recently, the level 1 evidence for effective stroke treatments could be summarised on one single slide. And you go to stroke meetings and there's lots of optimism about new treatments and therapies, and it's negative, neutral. It's been like that for a long time. But finally, we've got something to add to this slide this year, and I'll detail that in a moment. But the background is what we've had thus far has not been terribly effective. We're giving a little bit of aspirin very early on in the piece. About 1 in 100 decreased death or dependency, so it's not a very potent treatment. Been admitted to an organised part of a hospital with experts looking after you, certainly much more effective, but still not a huge difference. And then a step up, perhaps, intravenous TPA. And that's probably been the most significant change, but it's now 20 years of age. So basically the pivotal clinical trial published in New England Journal of Medicine was in 1995. And it only seems like yesterday, really, but that was a real crucial turning point in the stroke world. There's been lots of controversy amongst our ED colleagues and various pros and cons, but we won't go into that too much, except to say that it became a turning point in the recognition of stroke as an emergency. It was a great impetus for us to actually organise ourselves, and it involved lots of groups of people. It involved emergency transport groups, it involved emergency departments, radiology, neurology, and the whole face of how stroke was managed was transformed. And so I've been giving TPA for a long time, and in fact I think I was Graham's registrar at Royal Perth in about 99 when a patient came in. It was like about 45 minutes after stroke onset, and I read up on all this and it was all fantastic. And I thought, well, let's give it a go. And this was in the days before guidelines and pathways and people looking over your nose, and I just went ahead and gave it, and exactly as per protocol. I wrote stacks of notes about all the trial data and stuff, and then I had to figure out, what about all those observations and nursing bits and blood pressures and stuff, and guess who ended up in the hospital for the whole night doing them himself. So things have changed a little bit since then, but here's a case from about 2005, a big right MCA stroke. Looking over to the left side was impossible for him. He was paralysed in the arm, paralysed in the leg, typical big right MCA syndrome. And on the scan there's this pivotal little tiny bit of clot sitting here, this white stuff in the proximal branches of the middle cerebral artery is likely thrombus. And around in 2005 we were able to start doing a few more advanced imaging, and you can see the thrombus cut off there, but he's got a little bit of collateral flow here from his leptomeningeal vessels and perhaps a posterior circulation, but this side of the brain is certainly underperfused. We perhaps didn't really need to know that because we could see that in the patient himself, but I'm just showing this to illustrate what can be achieved. And on these settings, this is what we call a CT perfusion study. This is again not as nice and crisp as we can make today, but the summary is blue is bad. And after the TPA, this patient woke up, we were able to move his arm, move his leg, and within 48 hours he's walking around the ward, and the repeat CT perfusion, so the before and after is pretty telling. And so every now and then you get a great win like this, and it'd be fantastic, and everyone would be thinking it's fantastic, a miracle. But the more we used it, we run into problems, and I'll talk about the problems of hemorrhagic transformation later in the piece. But what really started to become problematic was the patients with the biggest and baddest strokes who've got lots of clot really didn't respond to this therapy. So, and observational studies really looked at the issue of how big the clot is on the bottom axis here versus the chance of actually successfully opening up that artery. And disappointingly, if you've got more than about 5 mils of clot, you're looking at only about a 50% chance of actually successfully opening it up. And once you're getting out to your 8, 9, 10 mils, it's getting down to about 0. And we kind of knew this from the patients in front of us. And so it became more and more that we could run down and give the TPA and think, wow, we've done everything as good a job we can, but we wanted more. We really did want to see these patients get better, because these patients with the big bad clots were not getting better. We are really privileged in this city to have access to interventional neuroradiologists, and we have about 4 world-class radiologists who for many years have actually become experienced in actually doing catheter extraction of thrombus. And over the years their technology has evolved and advanced, and there's been various different iterations, but the current favourite one is what we call a stent retriever. So it's a wire that would be used to actually encase an aneurysm or open up an artery in the cerebral circulation, but it also happens to be very good at pulling clots out. So as far back as the late 2000s, we started to recognise that we'd have patients come in, big stroke, we'd give them the TPA, and then if we identified by our imaging that there was more clot or big clot, then perhaps what we could do was whip them upstairs to the angiogram suite and concurrently pull the clot out, because we felt that was the way to go. And most of the work's been done on middle cerebral artery, but here's a basilar thrombosis. And remember that graph showed you the 5 mm cutoff. Check these out. You go fishing with these, they're enormous worms. And this patient was comatose, basically, with a basilar thrombosis and walked out of hospital. So this is just, when you see this happen, it makes up for all the bad sleepless nights of on-call and things, and it's just a true miracle of medicine. And so in the late 2000s, we started to actually routinely do this and offer it to our patients. We realised it wasn't sort of proven in the literature at this point, so we had a technique where they'd come in, get the standard IV TPA, and if a CT angiogram suggested a big amount of clot, they'd go up to the catheter suite, and here you see MCA branch. You should be seeing blood filling the right hemisphere here. Here we are, pull out the clot, restoration. And around this time, everyone would take photos of clot. You'd have clot cam gallery on your phone, and everyone would try and compare the biggest and best clot at the meetings and things. So we're pretty excited about this. Around this time, a lot of clinical trials were up and going, really exploring this. And it's interesting, it was a bit of an ethical dilemma, because we're actually pretty good at doing this, and our interventional radiologists, bless them, are interesting fellows. And we talked about becoming involved in one of the pivotal trials, which I'll show you the results of a little later. But they actually felt a little bit ethically squeamish about someone with big clot coming in and then randomising not to have this happen. One could make an argument that, well, we don't know about the complications of the procedure. Are there additional morbidities that would ensue from the anaesthesia, sedation, and the technique itself? It was pretty hard to convince them to actually become involved in the clinical studies. And we all got a bit of a kick in the guts in February of 2013 when the results of 3 trials looking at this paradigm of combination IV TPA plus thrombectomy all turned out to be neutral. Not negative, but neutral. Well, it's one of the terms I really hate when people say your trial was negative. Often trials are not negative, they're actually neutral. It can show a result one way or the other. And so there was a bit of a step back and people were a bit wondered, but fortunately things pressed on, and there were further trials in the wind, and within 2 years, so basically between 2013 and 2015, there were 5 strongly positive trials that have all come out to great aplomb and applause this year, and things have changed. And the first one was a trial called Mr. Clean in the Netherlands, but it's been followed by a whole bunch of other ones. And basically this slide tells us about the outcomes of patients. So there's all details about the clots and all sorts of things, but the take-home message is how the patients do. And in stroke medicine, we use this thing called the modified Rankin scale, which is a pretty coarse measure of outcome. So 0 is completely normal, 6 is dead, 4 or 5 are highly dependent people, often in nursing homes. And 0, 1 and 2 are pretty good outcomes. And you'll see if you've just got IV TPA, your chance of having an excellent neurological outcome were only about 1 in 5 at the best. But when you had the catheter technique added to it, check these out. So great differences between each of these trials. Numbers needed to treat enormous. So again, one of the most potent and effective treatments in all of medicine. And this has just recently been meta-analysed, and so you'll see the 2013 trials here, sort of left straddling the line, but the more recent ones pushing forward and becoming positive. And this has already been incorporated into guidelines. So that's why this will be considered as a pivotal year. 2015 will be considered a pivotal year in stroke, because now we really have identified and proven that the best treatment for large arterial stroke is to pull the clot out in combination with TPA, and to do it as quickly as possible. But it does come at a juncture to how to do this. And all these things are very well and good if you live in Netherlands or Dalkeith or somewhere down the road. And we've always had these great cases. We had someone who collapsed at their office in West Perth and came down in half an hour and bang, they're out. Well, what if you're living in Broome or Kununurra? Very, very difficult. So this is the current division of labour across the state. And so I like to say that Graham and I work on the world's biggest stroke service, at least geographically. And I might lend you this slide for your North American talks, Graham, for, just to illustrate to them how big WA is really. Because when someone has a stroke in the distant far, what can we do for them? And I'm glad the rural people are going to get this recorded, because I haven't forgotten them. Okay, we get very city focused, of course. What can we do? And you have to bear in mind that when you've got clots sitting in an artery like that, for every minute almost 2 million brain cells are rotting away, and there's been this famous calculation, mainly based on the IV stuff, but I think it's always very useful to remind our colleagues if there's some delays, when they say, oh, I'll get a scan in 10 minutes time, that's 20 million brain cells that are going to go. So hurry along. And I think the Spanish have done time in motion studies with cameras watching the stroke team, you know, looking at all the points in the process. So it's always good to keep this in the back of their mind. And so once the clot's set, there is cascade of various different biochemical processes get into play, ultimately leading to cellular death. And to really slow that down, you've got to act quickly. So is there a way of actually, I'll skip through these, so the time is brain. So can we get our ideal treatment to more people? So can we actually expand the window? Can we do something that might potentially get more patients eligible for what's really becoming the gold standard treatment? Clearly, organising our services is important, but you know, what can we do for our poor rural friends? So perhaps we could do something that opens up the time window or slows down the underlying process. Can we do something that could potentially perhaps slow down the ischemic process, and then it's still worthwhile pulling the clot out in the longer run? And so that's this idea of perhaps doing something out in the field, and a lot of stroke medicine is moving towards treatments in the field, and Graham and I have recently done an editorial on the whole concept of pre-hospital stroke treatments, and we looked at that a couple of years ago and tried to put it and frame it into an Australian context. This is my back of the room picture of a slide at the European Stroke Congress a few years ago with the German stroke ambulance, and inside that ambulance is a CT scanner. So they've moved forward to not just identifying people, but actually starting treatments out in the field. One of the things you need in stroke, we can be as expert as you like looking at them, but it's very hard to know, is this an ischemic stroke or is it a hemorrhagic stroke? So some form of imaging is needed to make that critical juncture. So the Germans are now followed by their colleagues in the US, are really looking at organising services to actually treat in the field. So very exciting. But again, how do you do that in Australia? I mean, you can't send an ambulance out into the country and do this effectively. So what about a plane? So initially I thought I was just joking, but I thought, well, why not? Why not? It is the future, you know. Where are the flying cars? And it struck me that, well, why don't you? And I'm actually just starting to tinker with the idea of trying to get a CAT scan into a plane. And the CT scan companies are putting these adverts about their smooth, light, mobile scanners that they can put into operating theatres. And I actually sent an email to one of them and said, oh, can you give us some more information? Here's the idea. And they said, oh, okay, we'll set up a meeting. So I've actually challenged one of the CT manufacturers to come up with something light enough to stick in a plane. And I had a chat to the head of RSDS the other day, and he said, oh, we get all these harebrained ideas all the time. But anyway, watch this space. You know, imagine if you could zoom your jet up to the northwest where they retrieve them, maybe from a mine site, maybe you could Fiona Reinhardt to fork up a bit of money or something. There may be ways. So anyway, something for the future. But the other interesting thing that's happening around the world is the concept of actually doing some treatment out in the field, as well as actually doing therapy, undertaking clinical trials. And our colleague in California, Jeff Saver, has done an amazing job with this trial called the FastMag trial, where intravenous magnesium, which is one of the classics as a neuroprotective agent, had a glimmer of hope in one of the traditional trials where you have your stroke, get taken to the hospital, get a CAT scan, get sorted out, get randomised, and the mean time to treatment's out there about 5 or 6 hours. Didn't show any positivity, but little glimmers. Pretty safe, pretty easy to use, pretty easy to administer. So what Jeff and his colleagues have done was they actually organised a very amazing trial where patients would be recruited and enrolled in the field. So the ambulance officers would identify patients who had a stroke, phone the investigators, and half of them, I think in English, half of them in Spanish, being in California, were able to get consent in the field and commence treatment out in the ambulance before they got to hospital. So almost 3/4 of them enrolled, less than 60 minutes post-symptom onset, and here are the figures here. So treatments previously that might have had a glimmer of or whiff of success at that longer time window, perhaps we can now study them much earlier and perhaps if we've missed a treatment effect, we might be able to detect it. Sadly, the results were neutral, but this is serving as a great model for things that can be done down the line. So what could we potentially do? Could we do combinations of things? And Bruno Maloney in his lab here have done lots of work on hypothermia and magnesium as individual agents and in combination. And they in fact predicted that FastMag would be negative because they had found in at least their rat models that it needed that combination of the two together to actually have an effect. So perhaps there are things that we can do out in the field. Perhaps there are very simple things such as positioning of the head to alter an impact on cerebral blood flow. There's the world's biggest nursing study of stroke, or probably the biggest nursing study of any kind, is about to be underway, and we're going to be part of it, where patients are simply going to be randomised to being nursed flat versus nursed at the traditional 30 degrees. Because there's some early ideas that you can have about a 30% increase in cerebral blood flow with straight recumbency. So perhaps sticking someone down flat, administering these things in the ambulance might all make an impact. And there's little whiffs of other neuroagents in the wind, so just literally 100 200 metres away from it, Neville Nucky's lab with his team there have had some success this year with various different compounds. And part of my NRP work has been to look at minocycline, old-fashioned, long-standing antibiotic, usually used for acne, other serious infections. It's had a lot of interest in neurology for some time with various possible mechanisms of action, but it may even be, apart from these fancy mechanisms of action, perhaps actually preventing the development of sepsis and inflammation in the initial days after stroke might be one of the keys here. And the story goes back to David Prentice at Royal Perth Hospital, a general physician, has been interested as well in this for a long time. And he recounts a story where he'd seen a patient who in fact was a physician, and it's actually public knowledge because it's been in the media, had an out-of-hospital cardiac arrest in Kambalda. And he was down and out. And they resuscitated him all the way from Kambalda to Kalgoorlie and shipped him out by RFDS, adrenaline, the whole, everything they could give, down to Royal Perth, and he was fine. And brain was fine thereafter. And what David was interested in, he'd been on doxycycline as an anti-malarial prophylaxis, having been on holidays overseas. And that, I think, really tweaked David's interest in minocycline as a neuroprotective agent. And around that time, a small study out of Israel came out looking at oral minocycline administered within the first day or so after stroke that looked promising and in fact had a positive result. So David got really interested, and he knew that Graham and I were interested, and so we actually started to explore this a little bit more. And I think somehow David had managed to get hold of some intravenous minocycline for some patient, a lung transplant patient, I think, at Royal Perth, or a heart transplant patient who had a really multi-resistant organism. So we were able to source an intravenous minocycline, and then we thought, well, maybe in stroke patients who can't swallow and not absorbing things, maybe we'll try that instead of the oral form. And so there'd been a few dose-finding studies that had already been done, and there's a chap in Atlanta, Georgia, David Hess, who's very interested, and he's done a lot of the initial experimental animal work and then clinical work as well. So we started to look through what was available, and one of the things that looked logical was to combine TPA and minocycline. And the classic middle-cerebral occlusion experiment in rats. So here's what happens when you don't give any interventional treatment. Here's the 1 hour result with IV TPA. Here's what happens if it's 6 hours, and here's the combo with minocycline. So have a look at the difference here between a 6 hour without minocycline versus a 6 hour with minocycline. So this is sort of akin to the hospital model. So you get your mino first, perhaps en route to the hospital at 4 hours, and then you get your TPA out here at 6 hours. So that's the purported difference. So this actually looks all quite interesting. And so we ended up doing a study, and the acronym was the PIM study. I've never had a sip of this stuff yet. I've got to do it one day. I think it's very English. And so we designed this study. And again, it was more of a pilot type of thing, really looking at the feasibility and adding to the safety data. And so we enrolled patients who'd had ischemic stroke. Some of them had some TPA, and this was back in 2010 to 2012. And the bottom line is we didn't really make much of a difference. We had a good try, but our endpoints and things, the big IV studies was very potent, needed sort of 500-600 patients to prove a difference. So we always had it as a pilot, but we proved it was safe. We actually got some experience with IV TPA and the combination, and we thereby added to the literature. We reviewed what the Israelis had done and another small study out of India, and we dragged the meta-analysis back a little bit. But so still out there in the wind. But the other aspect of minocycline that I was interested in was the idea of perhaps taking a slightly different approach. So rather than the traditional neuroprotective approach, seeing, particularly because it has this property called inhibition of matrix metalloproteinases, which are chemicals in the blood vessel wall and connective tissue that keep them all together and strong. And in stroke, those tissues start to break down and can lead to bleeding. And this is what we always worry about after our IV TPA. So for the patients in the audience, when you have your stroke, your brain is like a sort of soft, mushy bruise. And not only is the brain tissue ischemic and under threat, but the blood vessel wall is potentially leaky as well. And this little cartoon just shows a clot sitting here in the blood vessel wall. The blood vessel wall constituents deteriorate because of the damage from the clot. And then if that clot's removed, either spontaneously by fragmenting and breaking on, or if it's mechanically pulled out, or if it's actually dissolved by the thrombolysis, you have a situation where you've got blood rushing back in, but you've got a leaky blood vessel wall. And so that's the big worry. So if you actually pump bleeding out into soggy brain and you get increased intracranial pressure, the mortality rate is at about 50%. So it's a bit of a disaster when that happens. And roughly 3 to 6% of cases will have that perilous scenario develop. So what I thought, perhaps we could look at something that made IV TPA safer. And so that improves the risk-benefit ratio of things. And so this had actually been done in rats. So here's, again, a rat model, but given with a big slug of IV TPA. And so they're having about 50% of the animals getting bleeding. And this is pretty gross macroscopic hemorrhage. But when they combined the TPA with minocycline, look at this, pretty impressive reduction. And this is their sample size, so pretty smallish numbers. So again, we thought, well, we've got some experience with IV minocycline. Perhaps we redesign a study with the NRP's assistance that looks at the specific thing, to look at, is this a way of reducing hemorrhagic transformation after intravenous TPA? And again, a pilot study. So these were patients who'd had standard IV TPA up to 4.5 hours, and they were concurrently treated with IV TPA and minocycline. And the primary endpoints are going to be radiological. There are assessment ways of looking at CT scans to look at this hemorrhagic transformation. We designed our own way of looking at MRIs. MRIs are much more sensitive. In fact, if you actually do a standard MRI scan in the first few days after a patient's been treated with IV TPA, there's about a 40% chance of finding little speckled bits of blood within the infarction. And so we felt that if we could look at the MRIs in some detail, that might give a greater yield and a bit more power in our study. And so we ran this for a couple of years with most of the patients coming out of Charlie's. Swan District did really well. Unfortunately, Fremantle didn't really get up and going, and Royal Perth contributed a few as well. Again, sort of in a pilot type of fashion. I'd always hoped that we might be able to at least get the same number of humans as we were in the animal studies. It's probably not a very scientific way to design a trial, but at least that was our time window. And we got it up and going, and one of the things that made it a bit difficult for us really was the fact that at Charlie's a lot of patients were already getting thrombectomy, and one of the reasons we didn't include our thrombectomy patients was that often they'd get a little bit of other forms of blood thinning medications. So when the radiologist is trying to pull the clot out, he might squirt in a bit of extra TPA, a bit of other drugs called ReaPro or other antiplatelet therapy. So it was a bit of a mixed bag of the blood thinners that have been used, and we wanted to avoid that, because when you just give IV TPA, it's a very standardised protocol. Everything is the same dose per kilogram, observations are very the same, and that's how you want a scientific study to be, very well measured. And so we ended up getting 23 patients in each group. I won't go through all the technical details, but the take-home bottom line was we looked at the amount of patients in each group who had bleeding, and it was pretty much the same, frankly. So statistically, there's no difference. The bleeds on CT scan in the treatment group are illustrated here, and the bleeds in the group that were on the control group were here. Now, our radiologist is currently looking at this in a little bit more detail in terms of the volumes and things, but at a broad level, the trial is neutral. But it's interesting that perhaps what we've got in the control group looks a little bit more severe than in the treatment group. But watch this space, we'll get this all analysed and looked at, and we've got the MRIs to all consider. So I still haven't lost complete hope on it yet. I think there still is something in it, and I've sent emails, and I've actually had some inquiries from other people around the world who are still interested in the whole paradigm, particularly the guy in America, David Hess, who had actually contributed, put in a couple of big grant applications to the American funding authorities. But the world of stroke is really changing a little bit now with the advent of the mechanical clot extraction. How we incorporate that into our future studies of neuroprotection, when we start it, for example in the ambulance versus not, is all up in the air. So that's another part of the great excitement of 2015. Now, I've deliberately rushed a little bit to make a few extra comments, because one of the things in stroke, we always get hung up, we get very excited about ischemic stroke, so clotting kind of stroke. And like I said, this year's been a fantastic year because we've found some positive trials, but we forget about our poor patients who've got hemorrhagic stroke. And hemorrhagic stroke is a devastating illness. And its sort of treatment protocols and where it is at is a bit like where we were 30 years ago in ischemic stroke, with the sense of not really being able to do much. And we'll run down to the CT scanner and think, oh, we're about to do the clot busting medications and pull out the clot, and then our hearts sink when we see this. And the mortality of this is enormous. So an old observational study tried to look at the mortality, comparing the Glasgow Coma score with the volume of the hemorrhage. And if you've got more than 60 mils of blood in your brain and a GCS of 8 or less, that's 91% of people dead in the first month. So this is a devastating condition. People have tried surgery, sucking bits out, all sorts of stuff. We've tried pro-clotting drugs like recombinant factor 7. That seems to help. So the same drug that you might give a haemophiliac who's got a bleeding disorder, and that seems to reduce the hemorrhage from expanding. And what hemorrhages do is they expand with the course of time. And so we've had some success in minimising expansion, but at the price of more clotting problems. So you flood the blood with a pro-clotting drug, you might slow down the formation of this hematoma, but then you have heart attacks and you have pulmonary emboli and clots all over the place, or ischemic strokes. So you might push the blood pressure down, and we've been involved with a couple of international studies that looked at aggressively lowering blood pressure by IV infusions of multiple different medications, and that might decrease hematoma expansion by a little bit. So everything we've got in terms of surgery, medical therapies, manipulation of physiology has not led to any sort of great advance to this devastating illness. We are able to measure it a little bit more now. We can see what's going on. So in the same way we've done those CT angiograms and perfusion studies, we can do CT with contrast in our hemorrhage patients. And a few years ago, what have we got here, 2010, there's a bit of excitement about this newly described dot sign. So basically contrast extravasation within the midst of the hematoma was an indicator that the hemorrhage was still enlarging. And probably what happens with these hemorrhages, we'll just go back a slide, is that a small, tiny penetrating blood vessel, perhaps one that's been hammered by hypertension for many years, suddenly bursts. And then with each beat of the heart, more blood pumps, and the hemorrhage enlarges. And we know from observational studies that about a quarter of patients will have a significant enlargement by more than a third within that first hour. So this is happening right under your nose, so the blood's getting bigger and bigger and bigger. And probably what ends up happening is that the pressure effects of the raised intracranial pressure eventually equalises the pressure within the hematoma, and it all tamponades itself down, and the blood vessels sort of squeeze themselves and eventually comes to a halt. So that's what we think the pathology is. And so there's an idea that perhaps we could be a bit more selective with our patients who are getting some of those treatments I mentioned before, like the pro-clotting medications. So perhaps only target the ones who've still got hematoma that's actually oozing and leaking, and then you might be really enriching your study with patients who could potentially benefit, and you might thereby avoid some of the complications. So again, a bit of a sideways look. But I challenge all my registrars all the time, can you think of some way of doing this differently? I think you really need something original, something different, some way of really tackling this problem to sort of minimise this hematoma and to really slow it down. And a few years ago, one of the current consultants, Tapua Masuka, who's at Fiona Stanley, and I wrote an article for a journal called Future Neurology. So ideas about what could be done. And we did this chapter on something called hemorrhagic stroke in 2020. And one of my silly ideas spawned, I'll show you in a moment, But just back on what we can see, so as our scans have got better and better, really high-powered MRIs have been able to sort of witness the sort of rupture of these little blood vessels. So this is like the big middle cerebral artery, like I showed you before, where the clotting kind of strokes occur, and off the middle cerebral artery there is a leash of very small blood vessels, about 50 to 100 microns in diameter, sort of called the lenticular striates. And it's the wall of those little fragile blood vessels that's intensely vulnerable to hypertension. And the doctors in the room have done neuropathology. You might remember the old Charcot-Bouchard aneurysms. This is where these form and rupture and burst. And so you can now see them. Now, it's interesting that if we take a side step, when you have an ischemic stroke and you have the guys putting their catheters up here, pulling the clot out of this area, one of the little problems that they can encounter is that their catheter and their wires can nip off the orifice of these penetrating blood vessels. And so what they can do in their endeavours to actually try and pull the big clot out of here, or in fact when they've been doing things like aneurysm surgery or aneurysm procedures or catheters, they can inadvertently block that over and lead to an ischemic occlusion of these small penetrating blood vessels, and that had been reported as a complication of what these perforator arteries. So again, wild idea. Maybe one of the things you could do in the setting of a hemorrhagic stroke, so here you've got the little aneurysm, it's burst, it's bleeding. Perhaps what you could do is intentionally nip that off. Perhaps have some sort of stent or thing where you deliberately occlude the origin of the vessel, so you wind up with actually an ischemic occlusion of that artery to stop the bleeding, rather than having a big dead brain full of blood. Pretty complicated ethics getting people involved in that, I imagine. But, you know, wild ideas, I think we're really going to have something of this sort of ilk to actually combat a hemorrhagic stroke. And I'm glad I've run in front of time to maybe get that out, because we get so excited about our other stuff. I think we've really got to get a bit more knowledge about intracerebral hemorrhage. But there are other things on board in terms for ischemic stroke. There's interest that perhaps doing something mechanical to the blood vessel wall, such as instillation of sound waves. The guys in Texas have come up with this some years ago, and so the actual passage of low frequency sound waves through the thin temporal bone onto the middle cerebral artery had been a technique to analyse blood flow, to analyse reperfusion. But it had been observed perhaps that those patients did a little bit better, and there's been an idea that in fact the sound waves themselves are disrupting blood vessel, or the thrombus formation, stopping it sticking together, and may enhance the passage of TPA into the vessel wall. So again, perhaps you could have someone in the plane or in the ambulance where the angiogram is, the CT's been done, and then you could actually start by putting the sort of head frame on, and there in fact is a trial looking at exactly that kind of thing. So stroke's a great thing to be involved with. There's lots of other things which I've barely touched on, but I do want to find, with a little plug for what we're doing over at the Wanneroo next door, you'll see that there's a building emerging out of the ground, just literally metres away from us. That looks like a big hole in the ground then, but ultimately it will be like that. And within that there is a whole bunch of specialty clinics looking at a broad spectrum of diseases, not only including stroke, where Neville and his research team have been working, but also they've been leaders in things like muscular dystrophy and multiple sclerosis. And a lot of fundraising at the moment, really trying to develop some programs for a number of these conditions. And I've become a bit interested in trying to get something going for what we call restorative neurology. So our patients who suffer from stroke and ultimately have needed ongoing various different physiotherapy, speech therapy, cognitive therapies to try and get them moving and get them going again, are often, and they stay with me for life basically. I really want to see them do something better. And when I used to work at Shent's, we'd have these patients coming back for years, and they had various different phases where they get better, get worse. There's a lot of excitement in the restorative neurology field about the application of new technologies. Graham's big trial of fluoxetine may well be an adjunct, so there's a look at can we give some chemical stimulus to improve with brain reorganisation. But things like the robotic arm, so basically the patient plays video games on the screen and the arm moves around, and you can analyse how well they're going. And it's thought that what they can do in an hour on the robotic arm is a bit like 40 hours of occupational therapy. There's a lot of interest in virtual reality games, and recently we've hooked up with the IT department at Murdoch University and basically just play like an Xbox game where the patient looks at the screen and the camera looks at them, and we're in the process of designing some various games that will activate certain movements. I don't have a video to show you, but one of them we've got is like the patient, they feel like they're a birdman flying through the air, and they've got to go through little hoops. To get through each hoop, they've got to raise the arm up in the air. So the IT students are making all these games where you've got to do certain movements, like they're doing a sword fighting one where you can do extension of the arm, and we're enlisting some physiotherapists from Fiona Stanley to sort of get involved with that. So there's all these interesting things happening at the moment. What else? And to finish up, Graham Hankey in the audience is going to give a talk, probably on a slightly different emphasis in a couple of weeks' time. So make sure you come to his talk as well. Okay.